Dr. Abbasi is going to talk about minimally invasive scoliosis surgery with transcambin posterior oblique lateral lumbar
Dr.
interbody
Abbasi, we don't have a pre-recording from you.
study. Thanks, Dr. Abbasi, for calling in and looking forward to your presentation.
Dr. Abbasi, we don't have your pre-recording.
Oh, you don't have
we
my
only have a
pre-recording?
live presentation for
Can't
you.
hear you.
Okay,
So you have to,
do you have the
minute.
presentation?
so you have to run the presentation on the fly. Are you ready?
I have the. If you have the presentation, you can run it. How do I control it?
Yes, I will give you a second. Now you have control over it. Now you should be able to open it.
Okay, thank you for your time. I'm going to talk about the minimal invasive scoliosis correction with transcambin approach. And this is practically a segmental correction of this lumbar spine with transcambin lumbar interbody fusion. And certainly there are open techniques, and in our series, all the patients underwent transcambin minimal invasive approach, which utilize posterior, not anterior, OLLIF, oblique lateral lumbar interbody fusion, and in certain cases as well, minimal invasive direct lateral approach that goes anterior to the nerve root. Combination of these two allow us to achieve placement of the cage in a strategic location to correct for scoliosis. This was a feasibility test, but meanwhile we have done over 300 of these cases. The paper was published a while back. Here you see the marking on the skin for the transcambin approach. Number 2 is the oblique lateral posterior lumbar interbody fusion that is performed through transcambin approach. A series of smart tools are used to go through a tube and perform discectomy and practically prepare the end plate, put the graft, and then posterior percutaneous screws are placed. The two techniques, OLLIF and MIS-DLIF, as are demonstrated here, are practically through transcambin approach in the OLLIF and anterior to the nerve root, as you see in the x-rays on the bottom. And this shows on the skin the direction and trajectory of the disc that is important to mark during the surgery. And then we enter the disc after we use a neuromonitoring probe, make sure that we are not too close to the nerve. We then put a K-wire. Over the K-wire, a dilator is placed, and then a cage is strategically located to correct for deformity. Here you see the cages are eccentric. These are PEEK cages, but meanwhile we are using titanium cages. As you see here, we use the fulcrum, practically placement of the cage in strategic location to create not only coronal but as well sagittal correction. And here you see the osteophytes that are elevated, and that we have shown that we can correct 3 to 7 degree per level. In most of the cases, about 5 to 6 degree correction could achieve with every single cage placement. We could show that our patient ambulate, as a matter of fact, 96% of them within the first 24 hours. For that reason as well, vast majority of our patients are discharged within the first day. As a matter of fact, for 1 and 2 and 3 level, many of these patients are discharged within hours after the surgery. We could show that we can achieve significant fusion based on the reading of the radiologist. We are hypothesizing that because we are not devascularizing the bone by stripping the muscle, we can achieve higher rate of fusion. And as you see here, the patient could achieve significant clinical improvement after the surgery. I need to emphasize that the degrees of correction is only preoperative CT to postoperative CT. This is a comparable correction in that location. Our rate of infection actually has been 0.2% in the current study. In the previous study, it has been 0.33%. Only 2 infection in last 1,400 cases that we have done transcambin approach have been treated for infection. And I think I'm just going to stop here and pass it to the panel.
Now, my understanding with a posterior transcameron approach in the past have had a high incidence of axillary nerve root injury. Did you see that, or did you alter your technique to try to decrease that as a possibility?
Absolutely. Well, meanwhile, we have done 1,400 of these cases over 2,950 levels, and we have a comprehensive data regarding that. Whereas in the learning curve, that rate of nerve root injury or irritation, as we call, because many of these are just the numbness in the L5 and S1, is up to 12.5%. After the learning curve, that drops down to under 8% for initially. They have a very good prognosis. In another paper that we published, in 303 patients, only one patient had the symptoms after a year, which makes it a rate of 0.3%, which is actually at the lower rate of reported for open TLIF. And if possible as well, if there's one slide I want to show you from a different study that we talked about that regarding the durotomy and other risks, like in our group, in our series, our rate of durotomy was 0, whereas reported rate of durotomy has been reported up to 8.7% in literature for TLIF, especially after redos or after previous laminectomies. If possible, is it possible for me to show one slide, please?
I think we're actually going to run out of time. We just have about 30 seconds left. Do you want to make a final comment?
Yes, the final comment is that we had another study that we published regarding the obesity, rate of obesity and the duration of the surgery. And we showed as well that not only that, but a complication, return to work, and all the others. We could show that with the transcabin approach, all those rates are significantly improved. I have lots of farmers that they go back to work within weeks after multi-level fusion. We couldn't show any of these results with open surgery. Those patients needs months to recover. But that would be the last slide, and it might be available, and that as well is available online in our obesity OLLIF paper that was published a few years back.
Very good. Thank you very much. I want to thank everybody. Thank all the speakers for your excellent work. Thank you.